Hello, good evening, and assalamu alaikum, everybody. I hope I'm audible. So just let me know in the chat whether I'm audible or not. And I hope all of you are doing well. We are very sorry for the delay that happened for this rheumatology class, but we are all set here again. And it's so nice and exciting to see you all again. I hope all of you are there, and let's begin this session now. On a note, today we'll be talking only about autoimmune diseases because rheumatology is mostly that, and you don't have to think about any other findings except the investigations. No palpation, no auscultation, nothing, only the investigations. So let's just get ready and let's dive into it now. Okay. So here we are with the first question of the evening. Let's get into it. And the thing about rheumatology is you don't have many topics to cover in rheumatology, but so it would be nice if some of you would start answering, or should we wait some more? Am I audible to all of you guys? Okay, so great. And Karthik Priya, hi, Dr. Karthik and Dr. Aisha, good evening. So, all right, so you guys go with C. So let's roll the evening with C. And yes, anti-Ro antibodies are the one that we are looking over here. So we are talking about anti-Ro antibodies. We are basically talking about SLE, right? So the maternal antibodies being transmitted to the fetus is anti-Ro antibodies in 90% of the cases. Why is it not good? Because it is basically directed against your calcium channels, that is calcium L channels. They are activated by serotonin, so they are serotoninergic calcium channels. So you don't have to remember that, but just for your information, basically they cause heart block. So in the neonates, okay. All right, so there's a lot to learn about in SLE, and like I said about rheumatology, I just want to mention something, that there are not many topics, like I said earlier. So what the Royal College will do is they will go in depth with the topics. So you cannot have a superficial knowledge here. You need to be dead sure with your diagnosis, because the questions will be very close to each other. Okay, so it is definitely going to cause a diagnostic dilemma, because that is how it is designed. So you have to understand there are certain keywords, like I have always said. You just have to remember those keywords, and once you're sure of the diagnosis, please go ahead with that. Okay, So there are not many topics, so you will find questions repeating even in your exam. All right, I'll repeat that again. You will find questions repeating from the same topic in your exam. Suppose you get a question on reactive arthritis, there can be many questions on reactive arthritis. So don't be surprised when some of, or more than one answer to the question is reactive arthritis, just like that. So be aware of that fact and try to go in depth with rheumatology. Okay, so coming back, so SLE is more common in females. All of you know that. It is actually 9 times more common in females than males. Okay. The next thing is it is much more common in Afro-Caribbean population. Also in Asian populations, but for exam purposes, Afro-Caribbean you have to remember. Usually you will get the question stem mentioning a female of 20 to 40 years old having the symptoms, and the most important symptoms that sign, actually the most important sign that will always be present is your rash. Very characteristic butterfly rash. Okay, if there is no mention of rash in the question, I would say think twice about your diagnosis. Okay, associated antibodies will be HLA DR2 and B8, I suppose. Okay, and you have to remember all the HLA associations in case of rheumatology, because there is not much to remember here. And you basically have immune complex deposition in various organs of the body. All right. We will talk more about SLE and others as we go along. So you can have it in your skin and you can have it in your CNS. They can cause seizures. You can have it in your, let's say, heart. You can have pericarditis. You can have pruritus in your lungs. Okay, so that's about it. And now coming to the diagnostic part, most sensitive, or rather most sensitive is ANA. Please remember these terms because you will be tested. Also remember that ANA or any other things like rheumatoid factor or some things like these, they are not very specific to a certain disease. Okay, so they can be present in more than one disease, so don't get carried away. Always be on the lookout for these two. Okay, these two are the one that you have to be on the lookout. This is your anti double stranded DNA. Okay, this is very important. This is the most specific one, and also anti-Smith. Okay, but anti-Smith you won't find being mentioned so frequently in your exam. Be on the lookout for anti-DS DNA. C4 is going to be low because complement is going to be used up. Okay, do not rely on CRP. Okay, this is characteristic. CRP can be normal. CRP can be normal during the course of the disease or the flare-up of an SLE. Okay, now ESR is the one that will be guiding. It moves with the disease, follows disease progression. Okay, and most importantly, the problem happens in pregnancy. So SLE and pregnancy are not good. They are not good because together you will have anti-Rho and anti-La antibodies. Okay, so these two are the ones that will be present. Remember these two, but mostly it will be anti-Rho antibody, like I have said earlier also. Okay, So management will always be steroids, and in cases of the ones that are not being controlled on steroids, you will have to give cyclophosphamide. I think all of the topics that we are going to discuss today will definitely come up in your exam. Okay, but you have to be careful because the real problem will be in diagnosis. All right, I think this is enough for SLE for right now. Let's move ahead with the next question. Okay, Dr. Karthik says B. Hi, Dr. Pavan. Dr. Pavan also says B. And Dr. Aisha also says B. So let me change the color of the theme over here and let's go with B, fibromyalgia. Yes, all of you are right, and makes me extremely happy because diagnosing fibromyalgia now or even in your exam is not easy, but it is a diagnosis of exclusion. Okay, so the beautiful part is that you have not even looked at the investigations, and this is the one that is going to derail you from your diagnosis of fibromyalgia. Rest all of the investigations are normal. Okay, I'm just giving you out. So in rheumatology, just look out for normal investigations, and you will understand here that don't get swayed. Like I said, weakly positive ANA might make you think that this could be SLE or Sjogren's, like we just discussed. But like I said, all of these antibodies can be seen in various diseases. Okay, so fibromyalgia is a diagnosis of exclusion. What should drive you towards this diagnosis is three things. First thing is a chronic history. A chronic history is a very important factor in diagnosing fibromyalgia. You cannot diagnose a patient with fibromyalgia when the patient presents to you in an acute setting within, like, let's say a month or so. Okay. Then secondly, you have to understand that the creatinine kinase, CK, ESR, all these things should be normal, and you have to exclude metabolic conditions, mostly hypothyroidism. Okay, and also the patient will show signs of depression or low mood. Okay, not always in clinical practice, but in Royal College questions, yes, it will be there. Okay, so there's not much to discuss about fibromyalgia, and rest assured, if all the investigations are normal, you can go ahead confidently with fibromyalgia. All right, moving on to the next one. Okay, Dr. Karthik is quick to answer. Okay, pectus excavatum, and Dr. Aisha says B. Karthik Priya says B. Homocystinuria. Yes. So Dr. Pavan also says B. Okay. So I think Dr. Karthik wants to revise their answer. That's correct. All of you are correct. Downwards dislocation of the lenses is the one that points towards homocystinuria and not towards Marfan's. Let's quickly go through Marfan's and homocystinuria in a comparative fashion because this is going to come up in your exam. Okay, so I used to remember it like this. Marfan's guy is usually a tall guy with long arm span. So Marfan's is upwards, okay? And homocystinuria is lower. So let's quickly make a division. So otherwise, don't be very quick to be diagnosing fibromyalgia in your questions, okay? Here it's fine. So this is an autosomal dominant condition usually, and the major thing is fibrillin 1 gene, okay? And in your homocystinuria, you will be having a deficiency of cystathione beta synthetase. Cystathione beta synthase. Okay. Then yes, Dr. Karthik, you are right. And you have to diagnose it via genetic. This is diagnosed via genetic tests, while homocystinuria is diagnosed via blood and urine tests. Okay, so the major complications that we will be seeing here in Marfan's is that you will actually be tested in other questions. The first one is the major risk factor is dilatation of ascending aorta. Okay. And the next one would be MVP, mitral valve prolapse, okay, leading to mitral regurgitation. Ascending aorta dilation will also cause aortic regurgitation. Now, ocular, you will have ectopia lentis. So this will be upwards and outwards. While here you will have downwards dislocation of the lenses. Also, you can have heterochromia iridis, that is the iris being of different color. And other things, blue sclera is important in Marfan's. Okay, I think this is enough. And intellectual disabilities are important in homocystinuria, like Dr. Karthik pointed out. So I'll mention it here. And I think that should be enough. For Marfan's, you have to do regular echocardiogram. Welcome and hi, Dr. Reggie, if I'm calling you correct. All right, so let's move ahead with the next question. Needless to say, all of these diseases are autoimmune diseases, so don't have to repeat that in all questions, I guess. This one is straightforward. So anybody else apart from Dr. Reggie wants to answer? Dr. Reggie says A, and Dr. Karthik says A. Dr. Pavan, Dr. Satyam, and Dr. Aisha, I'm waiting for your answers. Okay, Dr. Aisha says A. And okay, great. So all of you say A, so let's go with A. And the three things that you have to remember in Behcet's is patient will always present to you with oral or buccal ulcerations. Okay, so that is the major problem to the patient. Oral ulcerations should be at least 3 times within the past 1 year. Okay, so that's how Behcet's is diagnosed. I'll just remove that and let's quickly get ahead. Okay, so I'll put that over there. So you should have oral ulceration at least 3 times in the past 12 months. Okay, there's basically the triad. I think all of you are very well versed with that. So this is the first one. And the second one would be recurrent. See, the idea is you do not have to forget the word recurrent over here. Okay, recurrent genital ulcerations. Okay, and the third one would be ocular issues like you can have anterior or posterior uveitis, and you can also have retinal vasculitis. Behcet's is basically a vasculitis, right? So you can have vasculitis also, but these are the most important triad. Okay, you can also have some GI or neurological things, but remember these three, the triad. Okay, so this is the most important triad. You will definitely come across one question at least from Behcet's. All right, I don't think there's much to talk over here. Okay, so Dr. Karthik says A. Dr. Reggie says A. Dr. Satyam also says A, I guess. Hmm. Okay, Dr. Aisha says A. So let's move ahead. And yes, dermatomyositis is the correct answer for this one. Only difference between Dr. Pawan also says A, which is the correct answer, Dr. Pawan. So all of you are absolutely right. And I'm very happy to see that all of you are marking all of the questions correct in Rheumat, which is very interesting. So let's talk a bit about dermatomyositis. So as you know, the only difference between polymyositis and dermatomyositis is the skin involvement. And one of the options said inclusion body myositis over here, the B option. So this one causes distal muscle weaknesses. Okay. So you will have some things like heliotrope rash. Then you will also see Gottron papules. These are the heliotrope rash is the periorbital purple colored rash. And your Gorton papules are plaques found over the extensor surfaces. And the third one would be Scholl sign. So there'll be photosensitive V-shaped thing like over the anterior torso, that is the neck. So like how you wear a shawl like this, this is the arm and this is the neck. So this is the Scholl sign, okay? And you will also have certain nail changes. They will be dilated nail fold capillaries. They are called periungual telangiectasias. Okay. Great. Certain patients may have lung involvement, so they will also show certain antibodies. Show one antibody. Okay. This can be there, but this may not always be there. Okay. So don't rely much. Also, you can have anti-U1 ribonucleoprotein antibodies, but they are not very necessary over here. Okay. So except for the skin signs, polymyositis, that is proximal muscle weakness, is the hallmark. Patient says, I have difficulty in getting up. So that's how you diagnose. All right, let's move ahead to the next one. And yes, you have certain investigations on this one. So let me know when you want to see the investigations. Okay, so these are your investigations. Okay, Dr. Pavan says E, Dr. Reggie says B, and Dr. Karthik says E with the jets. And Dr. Satyam also says X-ray. Great. So, Dr. Reggie, do not be in a hurry. What I would like to advise over here is whenever the question stem mentions next investigation over here or in the question, next means the first one that you would perform over here. Okay, so just the routine blood tests were performed. So bone biopsy is something which is an invasive procedure and it's a technically difficult procedure. Yes, it's okay. You don't have to be sorry if we are not here to judge anybody. So, like usually bone biopsy would be considered whenever the question stem asks us about how to confirm the diagnosis. Okay, so if the question would be how to confirm the diagnosis, then we would go with bone biopsy. But over here, the first one would be pelvis X-ray. So yes, all of you are right. This is Paget's. Now the only difference between this and osteomalacia would be that in Paget's your calcium and vitamin D levels will be normal. Okay, so the most important thing is normal calcium levels, serum calcium levels, of course, and the normal serum vitamin D levels. Okay, so these two are very important, and very highly raised alkaline phosphatase, which goes on to indicate a high level of osteoblastic activity. If you did the X-ray over here, you would see the alternating bands. So this would be bone expansion and osteosclerosis and bone thinning. So both osteoclastic and osteoblastic activities are increased. High turnover is the word. I will write it over here. Okay. MRI of the bone is not important in making the diagnosis, and the usually you can also have neurological symptoms over here, but if you look over here, see the alkaline phosphatase is really high, so that's how you will differentiate it with osteomalacia. Okay, and also your vitamin D levels would be going lower in osteomalacia. Okay, so let's go ahead. If you see normal serum calcium with normal serum vitamin D levels and high raised alkaline phosphatase, there is no different answer than Paget's. Okay. So most of the questions will have a lot of investigations, not this one though. Okay, Dr. Karthik and Dr. Reggie says E, and Dr. Aisha also says E. Dr. Pavan also says E, and I also say E. So reactive arthritis, or previously called Rita's disease, is basically a classical triad, just like the ones. So if you look over here, you will have some inflammatory appearance to the aspirate, but no evidence of crystals, no organisms. Okay, so in this case, we'll have this could follow usually it will follow an episode of gastroenteritis or urethritis. So the triad would be, first one would be urethritis, then conjunctivitis, like they say the patient can't pee, can't see, can't bend their knee, so arthritis. Right, now usual organisms, infection elsewhere in the body, basically triggering an reactive arthritis. All right, The usual organisms would be Campylobacter, jejuni, Salmonella, most importantly, Shigella also. Salmonella and Shigella go hand in hand. And in cases of urethritis, you will have Chlamydia trachomatis. Right, so that's it. The organism will not be detectable usually in your urethral swab or stool cultures, but antibodies to organisms will be detected. So that's how you will diagnose. And I'm very happy all of you are actually right in diagnosing it. You have a lot of investigations today. Yeah, sorry. Okay, so all of you say B, that is periarticular osteopenia around the PIP joints. Okay, so this is rheumatoid arthritis. The age and the presentation is very typical. Usually in your questions, if they're mentioning the proximal interphalangeal joints, that is the PIP, it will point towards rheumatoid arthritis. If they are mentioning distal interphalangeal joints, they are trying to point you towards osteoarthritis. All right, so let's talk a little bit about rheumatoid arthritis. I know all of you are masters of this one, so don't need to talk much, but so basically you have swelling of the PIP joints. Then you have also have MCP and breast joints, metacarpophalangeal joints and the breast joints. At least 6 weeks, they say. Then you also have swelling, that is soft tissue swelling. Six weeks again. Morning stiffness. We are basically talking about American College of Rheumatology criteria, which is somehow used in the UK. You have symmetrical arthritis. and periarticular osteopenia or radiographic evidence. Loss of joint space is the first one that you will see on early x-rays. And juxta-articular osteoporosis and soft tissue swelling. Okay, periarticular erosions also. Periarticular erosion is not an early finding, but it's okay. So these are the findings, and then treatment would be initially you would start with two of the NSAIDs, and then later on you would go on to add the disease modifying drugs. They are called DMARDs. So and biologics also. So the most important one is methotrexate. You have to remember that you have to conduct uh, the blood tests every 2 weeks for 6 weeks, and then monthly ones. Okay, and yes, it is very heavily teratogenic, so you will not use it in cases where you are seeing that there's a female and there's chances of pregnancy, so you have to like strictly contraindicated in pregnancy. Then what will you use in pregnancy? It's sulfasalazine, hydroxychloroquine also. Then biologics will usually talk about anti-TNF agents, because TNF alpha is the major one which is causing all the damage over here. Okay, but simple thing, they can ask you which is the antibody and where they are acting. So the antibody is IgM antibody, okay, and it acts on the Fc portion of IgG1. A very simple basic question, but it can come up. Okay, so remember this. Now TNF alpha inhibitors, so this will be your infliximab and etanercept. So after 2 NSAIDs, if the disease is not controlled, then only you go to DMARDs. All right, so that's about it. And you can also, they can ask you, these can come up in your basic sciences question also. Rituximab is basically anti-CD20. Okay. A monoclonal antibody, so it acts on the B cell depletion. Okay. That's about it. So let's go ahead. There are other things associated with rheumatoid arthritis. You can have Felty syndrome, and that is splenomegaly with rheumatoid arthritis. You can also have other forms. You can have like septic and other things, but we'll talk about that later in the next questions. Yeah, let's get ahead. Yes, you can also have Kaplan syndrome. That's in association with coal dust exposure, Dr. Reggie, that you're talking about, right? Massive fibrotic nodules. Anybody else wants to answer apart from Dr. Karthik and Dr. Reggie? So we have different diagnosis over here, and okay. Anybody else wants to take a shot? Okay, so I think the thing that is causing confusion over here is joint pain and a dry mouth condition over here. So always remember that typical SLE features if you are seeing, but this sentence is the most important one. So as soon as the patient was taken off the drug, the patient returns back with the symptoms. All right. So let's see over here. I not mentioned about anti-UN antibody, so mixed possibility. Yes, yes, Dr. Karthik, you are saying right. Uh, it is difficult to take D over here as an answer because yes, like Dr. Karthik says, anti-UN ribonucleoprotein antibodies are not seen, so you cannot go with this one. But yes, the possibility of Sjogren's and scleroderma also is there because then you could always say that initially it is presenting like that. But then you have to understand that we are trying to mention a drug over here, and this is not a normal drug. This is a causative drug for drug-induced lupus. Okay. So if the question stem mentions that the patient was started on the drug and then the patient stopped, the drug was stopped and the patient returned back to normal, that is very classical of drug-induced lupus. Okay, so it will present in a very similar fashion to SLE, but the most important one that I have omitted over here is anti-histone antibodies. So your question will definitely mention this. Okay, even if your anti-single stranded DNA antibodies are not there. So these both of these are very characteristic for DLE. Yeah. So let's talk about the drugs that cause. First one would be phenytoin, very notorious. Second one would be chlorpromazine, hydralazine, isoniazid, procainamide. Okay, so these are your drugs that are usually implicated in drug-induced lupus. The symptomatology will be very similar to SLE. Okay, so you can have joint pains, typical Sjogren type syndrome also. So yeah, just look over here. The C4 is slightly reduced. Okay, so this is the word slightly over here is the one which is, I think, misguiding you. But then you also have to notice that anti-SS DNA is positive. This is very characteristic of drug-induced lupus if antihistone is not given. If antihistone is given, then go ahead with drug-induced lupus very confidently. Okay, next one. Okay, so Dr. Karthik and Dr. Pawan and Dr. Reggie and Dr. Aisha, all of you are answering D simultaneously. So yes, let's go ahead with glomerular IgA deposition. This is a classical case of HSP, that is Henoch-Schonlein purpura. Now this is basically an overlap with IgA mediated nephropathy. So this will cause an IgA small vessel vasculitis. A lot of features will be overlap, but the pain abdomen over here was characteristic giveaway for this one. So overlap with IgA nephropathy. That is the Berger's disease. Okay, so you will usually have young children, usually, although any age can be present, and there will be a history of sore throat. That is basically your group A streptococci. This will precede the HSP. Then you will have palpable, the clinical features will show palpable purpura. You will have abdominal pain. and it will progress quickly, okay, and it will be polyarthritis. And you can have IgA features like crescent formation in the mesangium, and other things like hematuria, proteinuria, IgA deposition. So be on the lookout for HSP. It will be there, and crescent will be there. Then this is usually a self-limiting condition. You can have use of corticosteroids, even cyclophosphamide, but that's very rare. Okay, so I will not write it over here. So that's not there. So if you have abdominal pain presenting with URTI previously and purpuric rash, it's classic giveaway for HSP. All right, next one. So Dr. Reggie says HLA testing for B27. Dr. Pavan says D. Dr. Aisha says E. Dr. Karthik, you would. I think Dr. Karthik has answered D, right? Okay, so Dr. Reggie, we are talking about most appropriate investigation to confirm the diagnosis. Okay, so let's go one by one over here. Okay, let's forget. I think we are all on the same page. We are talking about ankylosing spondylitis, so no doubt about that. Now, if we go with HLA testing for B27, 90% of the patients with AS will be HLA B27 positive, but 10% will be negative. So we will miss out on that. CRP not really required. CT of the lumbar spine. Okay, so we usually don't go with CT of the lumbar spine. Usually that investigation is not performed, at least for AS. Now the main differential remains between D and E, X-ray and MRI. Now if the question would have asked which of the following is the next investigation, then your answer would be X-ray, because it's easier to perform and it's quick to perform too. But if you have to be confirmed with the diagnosis, you have to perform an MRI. Okay. Also, if the question would mention, let's say, yeah, yes, Dr. Karthik, B27 will also be there in seronegative arthritis also. And yes, so I was talking about, if the question would say next, then you can go with X-ray. If the question says which one of the following is the most appropriate to diagnose the earliest changes, then also the answer will be MRI. Okay, always remember that the changes on X-ray are visible after, quite a lot after MRI. Okay, the first one will always be the first one will be X-ray, but the one to confirm the diagnosis will be MRI. If they ask you which one is the one that you have to detect the earliest changes, then it will also be MRI. Okay, I hope I'm making my point clear. So let's talk about ankylosing spondylitis. A very typical patient young adult male presenting with early morning stiffness being relieved on exercise. Okay, so very typical history. So young male, okay, 20 to 30s young male, okay, and they will present with early morning stiffness. What stiffness? Lower back. Pain. Pain actually presents a bit later. First symptom will be stiffness, but yeah, you have to remember both. Early morning lower back pain and stiffness. How it goes away? Goes away with exercise. They'll tell you, so we exercise for some 15 or we move around a bit, then slowly it relaxes. So that's very typical of AS. HLA-B27. Yeah, so this is important. Now let's talk about some of the features. The first and the most important feature that you have to remember is reduced lateral flexion of the lumbar spine. So if you do the tests and there is reduction in the lateral flexion and forward flexion, but the first one will always be lateral flexion, okay, first to reduce. Okay, so you will perform this, then Shobas test patient bends forward, and then you measure the line distance, how much it is increasing. I hope you know that it has to increase more than 5 centimeters. Okay, so yeah, other features would be starting with apical fibrosis. A for apical fibrosis on the chest X-ray. Then you will have anterior uveitis, talking about HLA-B27 again. All right, you will have aortic regurgitation. You will also have Achilles tendon issues, that is tendinitis. So A for AV node block, that is. And you can have cauda equina also, amyloidosis also, but they are not very relevant over here. All right, I think we have discussed a lot. There'll be questions you can, all right. So definitely you are getting a question on AS, be very sure about it. Like I said, I'll write down your thing. The first to diagnose will always be MRI. Earliest to diagnose will be MRI. Next investigation to be performed will be X-ray. Okay. All right, and that's about it. Let's get ahead. Okay, Dr. Karthik says B. Dr. Karthik also says what it is, that is tennis elbow. Yes, it is tennis elbow, Dr. Karthik, you're right. Lateral epicondylitis is the correct answer here. Okay, so now that the answer is there, let's talk about a little bit about the lateral epicondylitis, that is tennis elbow. not many tennis players will be presenting to you, but people who handle heavy equipments, handle tools that are heavy, that is more than 1 kg. So they are working with tools that are with their hands that are more than 1 kg, or they regularly lift loads that are greater than 20 kgs. So these are some of the pointers on the causative thing. Also, repetitive movements for more than 2 hours per day. These are some of the pointers. Okay, so not necessarily, but these are the ones. It's easy to diagnose, but difficult to treat because it keeps coming back to the patient. So you will be giving them strap orthosis, elbow strap that is there. And you can also give them local corticosteroid injections, but that is done later. And finally, in your very resistant cases, you have to do a release procedure. Okay. So all of you who are tennis fans could just write in your comment box which is your favorite. Okay. So we'll do this question and we'll take a break because I believe this question is related to the previous one. So Dr. Karthik seems to be a Djokovic fan, and sorryly enough, but Roger Federer, we don't get to see him play anymore. Not causing any fan wars over here. Um, okay, so the one is supraspinatus tendinitis. Sorry for the typo over here. It's tendinitis. It's supposed to be a D. Yeah, I think I've drawn it correct. Okay, so the important one over here is worse during the middle range of abduction. Yeah, so this is the most important term over here. Also, if you had to, like differentiated between adhesive capsulitis, so then this sentence over here, passive elevation is less painful. Now, passive elevation or passive movements are equally painful in cases of adhesive capsulitis. While in cases of supraspinatus tendinitis, your active movements are painful. Also, you have to understand that there will be a history of trauma, which is not given over here in this question. This rheumatoid factor weakly positive does not make any difference to the thing. Okay, so active abduction and elevation will always be painful, and passive elevation of the arm will basically cause the pain to go away because it will cause less impingement of the tendon, like the tendon gets trapped and gets pulled. So when you passively elevate it, the supraspinatus gets relaxed. So that's how it causes less pain on elevation, passive elevation, not on active elevation. All right. So yes, you are right. Let's talk about the next one. Let's see if you can do this one, and then we'll take a short break. Okay, Dr. Reggie and Dr. Karthik are quick to say adhesive capsulitis, like I said. And Dr. Pawan and Dr. Aisha, what do you think? Yes, Dr. Karthik, this is a frozen shoulder, very characteristic of a diabetic patient. So what happens is the microvascular damage that goes on is the one that doesn't let the shoulder repair itself correctly. And that is why you get this frozen shoulder, okay? So you can also have it after a rotator cuff injury, okay? So remember it that your questions basically from RCP will focus around diabetes. If there is the word diabetes in that, think of adhesive capsulitis or frozen shoulder. Both active and passive movements will be difficult, okay? So that is the differentiating factor between the two. If both the active and passive movements are difficult, it is frozen shoulder. If the passive movement causes less pain to the patient, then it is a supraspinatus tendinitis, okay? So just remember this, and yeah, so I think that's about it. Like I said, the microvascular damage that goes on in diabetes doesn't let the body repair the tendons. Like, it's a very fine process going on in repair, like it goes on very slowly and very fine process. So because of the microvascular damage, it is not being able to repair itself correctly. Okay, so let's take a short quick break and we'll get back to you. All right, let's see you in some time, and don't go away. Yeah. Okay, so hello and welcome back, everybody. We are back here to start with our session. So let's dive straight without wasting much time. I hope all of you are still there with us. And so the next one is this one. Okay, so Dr. Karthik says double A. So yeah, A is the correct answer here. And anybody else wants to join? Dr. Pawan also says A. Absolutely right, Dr. Pawan. And this woman has osteoporosis, and we will know why she has osteoporosis, because for the purpose of diagnosis, we will use T-scores. T-scores greater than -1 are normal. T-scores from -1 to -2.5 is osteopenia. T-scores lesser than -2.5 will be diagnosed as osteoporosis. Okay, so you will basically begin bisphosphonate treatment over here. All right, Some of the questions, and some of you have been asking me this thing before, that if the patient is on steroids, then treat like one level above. Okay, so you have to give early bisphosphonate treatment. So -1 to -2.5, you will give bisphosphonate treatment. Okay, the diagnostic criteria remains the same, the treatment modality changes. Okay, so that's about the T scores. Okay, so the next one. These are the investigations. I will mark it for you to understand quickly. Okay. Um, Dr. Karthik, you have to notice that the patient is having some level of kidney impairment over here. So you cannot ignore that. And also, according to the ladder, WHO pain ladder, it's okay. You don't have to be sorry for anything. We are all learning over here. Yes, you are absolutely right. So we will be going with regular paracetamol. Okay. So the first step in the ladder is paracetamol for osteoarthritis, and that is what we will be giving to this patient. In cases of breakthrough pain, if she has, then we will give her diclofenac in case required. But with this level of you know renal impairment, we will usually not give diclofenac. Okay, I want something over here. Yes. All right. So that's about it. Uh, I hope I'm audible. Just if you could make sure. Okay, so all of you say A somehow, and Takayasu's arthritis, but that is not the correct answer over here. Let's go through the question and try to find out why. The first thing is the woman complains of paresthesia, okay, and pain affecting the lateral aspect of her right arm or whichever arm it is. Okay, so paresthesia and pain basically points towards thoracic outlet symptoms like syndrome. Okay, so also I think you guys are guided by the term that the pulse in her right arm disappears when she raises her arm above her head, but then there is no difference in the pulsations. In cases of Takayasu's, you will have difference in the pulses. Okay, the pulse in her left arm or right arm will be different. Okay, so Takayasu's is a large vessel vasculitis, and thoracic outlet syndrome is different. Okay, you will have autonomic features such as cold hands. You can have sweating. You can have paresthesias, and you can also have blanching. Okay, so I'll just write it down for you guys so that you don't get confused in the exam. You can have paresthesias, and you will have cold hands. These are autonomic features. Okay, you can have blanching, and Doppler and plethysmography. Adson's maneuver is the one that you will perform here to rule out the thoracic outlet syndrome. Okay, and one more thing I would like to mention here is in cases of Takayasu's, in your exam, I mean, I don't know how far this is true, but Japanese origin of the patient will definitely be mentioned in your question stem. Okay, somehow. So remember that, and also there will be different symptoms like difference between the blood pressure between both arms. Okay. This is very characteristic of Takayasu's as far as RCP is concerned. Okay, so let's go ahead. Okay. The investigations show that the urate levels are severely raised right now. That's the only thing given over here. Okay, so anybody else wants to answer? Dr. Karthik says A, Dr. Pawan says D, Dr. Aisha says A, Dr. Okay. Welcome, Dr. Punmagar. I see that you are also answering. And Dr. Reggie is not answering right now. That's okay. So let's start allopurinol once the 2-week time period is over. Okay. Because acute flare-up of gout, you are never going to start allopurinol. Okay, the whole idea is allopurinol, your regular xanthine oxidase inhibitor, so reduces the production of MSUM, monosodium urate, microhydrate, but the idea is uric acid crystals. So the uric acid crystals over here will be, these will be fine, long, needle-like, and they will be negatively birefringent on polarized light. Okay, so that is about it. And the other things that need to, do not use allopurinol in acute gout. This is the takeaway point. Okay, so another thing is pseudo gout. So you have calcium pyrophosphate crystals over here there. These crystals are deposited in the synovium, so these are both synovitis. And these are rhomboid shaped, small, and positively birefringent. So that is how you will differentiate between the two. And as far as D is concerned, for an answer, you don't need to escalate the treatment right now. Okay, the patient is controlled. This acute flare-up is having a good response, like it is mentioned over here. So you don't have to escalate the treatment right now. Okay. Yes, you can use colchicine during acute gout, but you don't have to use colchicine because, like just now I said, he continues. Let's go through the question. So the question says he continues to use ibuprofen during the course of the acute flare-up with a good response. So why would you want to escalate the treatment, right? So once the patient is not being controlled on a regular NSAID like ibuprofen, you would want to use colchicine also in cases of patients who are having CKD or whose kidney functions are not good. So let's say the creatinine levels were 299 over here. Then in that case, you can use both corticosteroids and colchicine, but then you have to decide. Okay. The whole idea is whether you would escalate the treatment in this particular case or not. Agreed, this is the third attack over past 6 months, but you do not have to escalate the treatment in this case because he is having a good response. Okay, all right. I think that makes the points clear. Let's go ahead. Yeah. Just in case if you want to see the options, I mean the investigations. Okay, so all of you agree with Takayasu's. So like I was telling you, you are right. Now if you note over here in this question stem, her BP in the left arm is 150 upon 70, while in the right arm it is 180 upon 95, which are different. So that is very classical of Takayasu's. All right. Yeah. So let's talk a little bit about Takayasus and how you will diagnose it. So any patient of Japanese origin in your RCP exam, okay, so you will have fever, weight loss, even you can have jaw claudication sometimes. But the most characteristic feature is difference in blood pressure in both arms. Okay, investigation of choice is MRI with gadolinium contrast. And treatment is very simple, steroids. For most of the cases that will come up in uh, rheumatology, treatment will be steroids. And you can also use steroid sparing agents like methotrexate, azathioprine, cyclophosphamide, but that will depend on the case to case basis. Okay, all right, let's move on. I suppose the question is quite big to read. Okay, Dr. Karthik Priya is quick to answer this one. And Dr. Pavan also says C. And Dr. Aisha also says C. And anybody else? Okay, so we will go with all of you. And it is C, polymyositis. We have already discussed this previously. But the whole idea is that the CK levels which are elevated over here so much is necrosis of the muscles. Okay, so that is what is happening in polymyositis. If you were to go with PMR, there will be no weakness. Okay, so the word weakness over here, there will be pain in cases of PMR, but there will not be weakness. Okay, and if you add on the skin findings to it, it will become dermatomyositis. Okay, so we have already discussed it before. And I will show you the investigations in a moment. Okay, so Dr. Karthik and Dr. Reggie and Dr. Pavan, Dr. Aisha, all of you are right again. This is polymyalgia rheumatica. This is a syndrome of, like, an overlap syndrome with temporal arthritis. That is, these are both on the different end of spectrum of the same disease. Okay, so basically you will have vasculitis with giant cells. That is the main thing in polymyalgia rheumatica, PMR. You will have an old patient. Okay, let me just write it quickly for you. You will have patient more than 60 years of age usually. Okay, and it will be rapid. There will be pain, but you have to understand there will be no weakness, unlike polymyositis. Okay, and you will have lethargy, depression, polyarthralgia, anorexia, the general features. Sometimes you can have night sweats, but that is not important. ESR will be mildly raised, and CK will be normal. So like you saw over here, ESR is slightly raised, rheumatoid factor is slightly normal, which is okay. Treatment will always be prednisolone. And small thing I want to mention over here is, like Dr. Karthik was telling it beforehand, this is very characteristic of mixed connective tissue disorder. Okay, so yeah, so you will have the features of SLE, systemic sclerosis, and polymyositis. So these will be there, and that's it. I think let's move on to the next one. Okay, welcome Dr. Hashir Malik. And you are right to answer this one very quickly. Dr. Reggie, Dr. Karthik, and chronic fatigue syndrome. Yes, you are right. We have already discussed fibromyalgia before, and I'll not go again in depth about it. But do remember that it's a diagnosis of exclusion, and the sleep disorder will always be present somehow in this one. So the sleep will be poor. Okay. So, Dr. Pawan, yes, hypochondriasis, like if you are trying to point towards that. Okay, so we it is written over here that you send, okay, you send investigations. That is, the doctor sends the investigations. In hypochondriac patient, it will be a different history, okay, and the patient will not be convinced that they do not have anything. Even with fibromyalgia, you cannot tell the patient that they don't have anything, because their complaints are genuine and they do have body aches, okay, although it looks like it is not there, but it is there, okay, and they suffer a lot, and there's a lot of work hours lost every year because of this, okay. And a woman in middle aged, disturbed sleep, okay, so you can go with fibromyalgia. All right, okay, let's try this one. So Dr. Punmagar says B and Dr. Karthik says D. Okay. If you want to see the investigations, but they are basically all fine. If you want to look at rheumatoid factor, it's negative. So it's basically not helping you much over here. Okay, so let's go with D, psoriatic arthritis. If you see an painful hands and like arthritic type picture with nail involvement, it will, yes, Dr. Hashir and Dr. Pun Magar, both of you are right as well. If you see nail involvement, that is fitting of the nails, okay, or if you see something like skin lesions developing with arthropathy. Usually the psoriatic arthropathy lesions, they precede the skin lesions, okay? So the psoriatic flare-ups will follow the arthritis. So usually you'll have the arthritis first, and you have rheumatoid like polyarthritis. You also have severely deforming fingers, and that is they call telescoping of fingers. So that will be there, telescoping. I'll write it down over here, okay? And arthritis mutilans, that is the later stage or extreme stage, you can say, wherein the joint gets deformed very badly, and you have to treat it like rheumatoid arthritis, okay? And the prognosis is good, but remember that the arthritis picture comes before the psoriatic flare up. Yes. Okay. Dr. Hashir is quick to find out that hyperferritinemia is the correct answer. And yes, Dr. Ashir, you're right. Yes, Dr. Karthik, you're right as well. Adult onset Still's disease is very much like juvenile Still's disease. Only thing you have to remember, yes, Dr. Regina and Dr. Aisha, you are right as well. I mean, sorry, Dr. Reggie, you are right as well. So but the idea is that it will give you basically rheumatoid-like picture. Okay, everything will be very similar to that except hyperferritinemia. Okay, ferritin levels will be raised, which is not usually seen in rheumatoid arthritis. Every other feature will be very much similar. That's how you diagnose adult onset Still's disease. There's nothing much in this, but you have to remember this one single word, and this is the only thing you have to pretty much remember for your part 1 exams. All right, so before you go on to answer this question, actually, let's deal with this one first. Yeah, please go ahead and answer this one. Great. So, Dr. Karthik, Dr. Reggie, Dr. Punmagar, and Dr. Hashir, and Dr. Aisha, Dr. Pawan. Okay, great. Dr. Pawan also answered. So, yes, so this is giant cell arthritis or temporal arthritis, and you can have skip lesions of the affected artery, but always remember that the priority in this particular patient is to save their eyes, that is the visual things, because they are at a very imminent, the very dangerous thing over here is the imminent visual loss. So the first thing you have to start is oral corticosteroids. Also, if it would be mentioned, you have to concomitantly perform uh, the temporal artery biopsy, but always choose oral corticosteroids first. Okay, the sooner you start the corticosteroids, the more chances of saving the eye of the patient. Okay, so usually the ESR will be raised, and it will be an old patient more than 50 years of age. First and foremost, always start oral corticosteroids both in your answers as well as in your patients. Okay, do not wait for confirmation via biopsy. Next, send the patient for biopsy. A negative biopsy report also doesn't rule out GCA or temporal arthritis, because you can have skip lesions. Okay, so if the question stem mentions that one of the biopsy came negative, then you cannot be very sure about it. Okay, this is the other end of the spectrum for PMR. Rest everything will be same lethargic features, jaw claudication, headaches, depression, low grade night sweat, fever, all those symptoms are same. Both are basically the two sides of the same coin. But the very important thing in this one is always remember oral corticosteroids in cases of GCA. The moment you read anything close to temporal artery, anything related to scalp sensitivity, and in an old patient, go ahead with oral corticosteroids first, and then send the patient for temporal artery biopsy to confirm the diagnosis. Okay, so this is the one. And guys, I hope you are enjoying these sessions. Thank you so much for all of your love and support. We really appreciate your time and efforts. Your exams are getting closer. Some of you are asking a lot of questions right now. So I just want to tell you that do not lose hope, even if you think wherever your preparation is. Nobody can say even after examination that their preparation is perfect. So don't get worried right now. Just focus on the exams, upcoming exams. Give your best shot. Don't worry about the outcome right now, because the world right now doesn't know anything about the outcome. So don't worry about it, and just give your best shot. Okay, and one nice thing that we'll do from now on is that since all of you are very shy of writing in the comment section, I will leave the question on the screen now, and you have to write the answer in the comments. Until then, see you and have a good time. Take care, prepare well. Thank you so much, everybody.